Hey, I'm Claire. I'm going to be presenting this presentation called Dazed and Confused, which is a guide to cognitive services in rehabilitation settings. Really quickly. That's me. I'm holding a crystal that I use in my brain injury room. It turns into a lamp. I'm not just like clutching a rock. And then also a hairball that one of my patients gifted me. I have been working for a TGH, specifically rehab, since 2018. Before I worked here, I went to grad school at UF, and then I completed my fellowship at the VA in San Diego. I did acute, inpatient, outpatient. I worked in long-term acute care, but I've mostly been camping out in rehab for, we're not too far from a decade now, so it's been a minute. So my only disclosure is that TGH pays my paycheck. That's it. So the objectives of this presentation are that we will categorize 6 common causes of cognitive impairment. We will discuss how the principles of ethics and neuroplasticity guide the clinical goal formulation process when determining how to address cognitive impairment. Here it says in inpatient rehab, but this is also applicable to really like anywhere along the continuum. Determine which diagnosis render a patient appropriate for restorative, compensatory, or medically supportive treatment, or a combination of any of the 3 to address their cognitive impairment. So part 1, we'll jump into diagnosis. So when we're diagnosing, it's important to consider that some things don't change with our cognition over time, but some change over time is not necessarily deviant. So things that might be reasonably expected to decline over time per Emory are your creation of new memories, your divided attention. You might have just like less snappy, complex attention with age, your word recall, retrieving specific words, like having some anomia every now and then is not particularly deviant. And then being able to adapt to new or unfamiliar problems or situations, and your reaction to information processing speed. All of that could decline over time, but not be considered a cognitive impairment. Things that we would expect to stay stable are your long-term memory or recall of those long-term memories, your focused attention, your verbal abilities, and your known or traditional solutioning, or things that are just generally more automatic to you. So we determine disorder via assessments. There are many options of assessments. The ones that we would generally see, usually at TGH, either in acute care or here in rehab, you have the MoCA, the SLUMS, the short blast test. There's a few delirium screeners. We have Glasgow Coma Scale, Ranchos Los Amigos for our brain injuries. And then when you land over here in rehab, we traditionally give the scales of cognitive and communicative assessment for neurorehabilitation, or in short, the SCAN. And there are other tests though. The R-bands is really solid and specific to brain injury. There is the Wechsler Adult Intelligence and Memory Scales. There's different neuropsychological test batteries. If you go get a neuropsychological test as an outpatient, they would give you a variety of things to test for that. And then there's delirium and dementia specific assessments, but at least I'm not doing them over here. So for all of you who are CVIS certified, if you go on their website, they have a nice little roadmap of cognitive impairment. This one's a little different from theirs, and I promise there's a good reason why. But we'll kind of jump into, this is how I felt it was the easiest to kind of lump the common causes of cognitive impairment that I see over here on the rehab side, and that you would also see in their beginning stages over in acute care as well. So number 1, you got mild cognitive impairment, dementia, neurodegenerative processes. Number 2, encephalopathy, which is what causes quote unquote delirium. Number 3 is autoimmune causes. Number 4 is functional cognitive disorder. Number 5 is paraneoplastic disorders. And 6 is acquired brain injury other. Now, Obviously, all of these are technically acquired brain injuries, but for the sake of this presentation, ABI other is referring to like your TBIs, your strokes, kind of when we say brain injury, what first comes to mind. So for mild cognitive impairment, it is cognitive changes that are significant enough to be noticed by the individual, but not bad enough to cause a decline in function. So they may see some short-term memory changes, some changes in different cognitive abilities like language, abnormal cognitive loss for their age or level of education. But otherwise, they're functioning pretty well in day-to-day life. So approximately 12 to 18% of people age 60 or older are living with a mild cognitive impairment, and an estimated 10 to 15% of individuals with mild cognitive impairment will develop dementia within the year. Dementia and neurodegeneration is an umbrella term that applies to a variety of diagnoses. The common ones are Alzheimer's, vascular dementia, frontotemporal dementia, Lewy body dementia, which is also kind of lives over there with your Parkinson's and Parkinsonisms, and then your others, which also down there says Parkinson's, Huntington's, HIV, Korsakoff, those things. Moving on to encephalopathy and delirium, this is our second category. So encephalopathy is the underlying medical cause or diagnosis, and delirium is the clinical presentation of encephalopathy. So encephalopathy is what causes your delirium. It's a group of conditions in which brain function is disrupted temporarily or permanently due to an underlying cause. It can present as memory loss, confusion, personality changes. So there's toxic metabolic encephalopathy, which is where the brain's function is impaired due to a buildup of toxins or metabolic imbalances in the body, or infectious encephalopathy, which is there's an infection and the pathogen does not directly invade the CNS or the central nervous system, but does have kind of an inflammatory effect on it. COVID delirium has something that happened to everyone very recently, and it is a specific delirium that is linked to the COVID-19 infection, often involving confusion or altered mental status. And then there's sepsis-associated encephalopathy, which is a body-wide infection that can lead to inflammation that's impacting your brain. There's other types of encephalopathy that are pretty common to see are hepatic. So that's liver dysfunction. If we're trying to kind of sort out if we think hepatic encephalopathy may be impacting our patient, the labs you might review are their ALT, AST, ALP, their GGT, bilirubin, PT, albumin, or total proteins. And oftentimes the doctors have already identified that there's hepatic encephalopathy at play. Wernicke's encephalopathy is when there is chronic thiamine or vitamin B12 deficiency. We see it most often in alcoholism, chronic alcohol use, or malnutrition. We would look at their BUN, their eGFR, creatinine, albumin, or their urinalysis. And then uremic is when there's toxin accumulation because your kidneys are not doing what they're supposed to be doing. Also looking at BUN, GFR, creatinine, albumin, or their urinalysis to see if something might be going on there. And then, of course, there's pharmacological considerations. There are certain medications that can cause and or worsen encephalopathy, things like chemotherapy agents, immunosuppressants, antibiotics, and then as well as their pain medications, opioids, and NSAIDs. In someone who has a baseline cognitive impairment, we would expect that they have a lower threshold for developing delirium in the first place. So something as subtle as a change in routine, circadian rhythm, increased pain, or hormonal shift can result in the development of what we would identify as hospital-acquired delirium, which is present in 50% of patients in the hospital who are 65 or older. So that's kind of like the state of confusion that you would find somebody in that's being caused by their encephalopathy. I find, at least in rehab, one of the things that strikes me the most about delirium is inattentiveness, like just very significant inattentiveness. The risk factors for developing delirium are if you have older age, 65 plus, hospitalization, especially length of hospitalization, If you are having difficulty ambulating, dehydration and malnutrition, infection, organ failure, being on a ventilator, or having recent oxygen deprivation, you have degradation of your senses or trouble seeing or hearing, nobody's put your glasses on you in like 5 weeks and your hearing aids are at home somewhere, or if you have a baseline dementia diagnosis. So you notice that they would have decreased attention. They have changes in awareness, not knowing where they are, changes in their thinking or thought organization. They may have a lack of interest in their surroundings. Sometimes they have like hyper attentiveness of their surroundings as well. Distortions in their sensory perception, hallucinations. My favorite ones are the people with like the cats jumping around the room. Get that one at least once a year. Delusions, and then euphoria, anxiety, or agitation. Next up, we got our autoimmune conditions. So these are things like encephalitis, our lupus, multiple sclerosis, Sjogren's disease, or rheumatoid arthritis. Basically, the autoimmune disease is causing inflammation in the body that also impacts our brain functioning. Number 4, we got our functional cognitive impairment, which per this definition is persistent, troublesome, subjective cognitive complaints that are inconsistent with a recognized disease process. There are significant discrepancies between what the patient will report to you versus what you are noticing or testing in your session. People tend to function better when they're not under constraints in functional cognitive disorder, and you might see or expect their function to decline once they are in a more constrained or task-specific environment. Number 5, we got our paraneoplastic, which is kind of like an autoimmune. It is an autoimmune response. It's not an autoimmune disorder, but it's similar in that it's an autoimmune response to the presence of cancer in the body. And so it's cognitive dysfunction and behavioral change that can be a manifestation of cancer occurring as part of a paraneoplastic neurological syndrome. And it's most commonly occurs in small cell lung cancer. And then autoantibodies are the main contributors to the development of cognitive dysfunction and behavioral changes in cancer patients. So anti-NMDAR and anti-AMPAR are antibodies that are targeted against surface antigens, manifesting predominantly as memory disturbance, abnormal behavior, psychiatric symptoms, and seizures. I actually think the psychiatric symptom portion of this is really interesting. We recently had a patient who had small cell lung cancer who had a lot of behavioral components to being admitted here. And after reading through this definition, it made a lot more sense why. And last but not least, and also the patients that we, at least in speech language pathology, typically treat are people with acquired brain injuries or, the other category in this presentation. So this is going to refer to our anoxic brain injuries, our cerebrovascular accidents, our brain tumors, and our traumatic brain injury patients. Acquired brain injury is, at least the ones we're specifically talking about today. Traumatic brain injury is when there's an external force to the head, and the causes include falls, motor vehicle accidents, sports injuries, assaults. And then there's non-traumatic brain injuries as well. It's caused by an internal force, such as a lack of oxygen, pressure from a tumor, etc. So near drowning, aneurysms, tumors. A stroke or a CVA is when the blood flow to the brain is interrupted, which causes cell death. It can either be ischemic or hemorrhagic. And then depending on the location, severity, and frequency of a brain injury, you can have a variety of constellation of cognitive changes, including but not limited to memory, attention, problem solving, executive functioning, processing speed, and comprehension. On brain tumors. So a tumor is an abnormal growth of cells within your brain, which can be benign or malignant, depending on location. It can impact a variety of cognitive domains. There is injury to the brain from internal force exerted on the tissue from the tumor growing, or the vasogenic edema, which if you pull up their head CT, you may see that listed, vasogenic edema. Common types of tumors astrocytomas, meningiomas, oligodendrogliomas, but there are other more rare types too. And then, of course, once a patient starts their treatment journey, they may receive chemotherapy or radiation depending on the recommendations of their oncologist. So it aims to kill your cancer cells. Chemo uses pharmacotherapy, while radiation is high energy particles to that specific tumor location. And then chemo brain is also called chemo fog, which is a cancer-related cognitive impairment or cognitive dysfunction. Sometimes the patients who have tumors, if they're eligible, have craniotomies. This is where they remove part or a good chunk of your skull sometimes, or rewind. Craniotomy is where they go through the skull and oftentimes through like a burr hole. Craniectomy is when they remove an actual chunk of your skull, but that's not really applicable to tumors. That's applicable to more commonly seen in stroke, hemorrhage, bleeding. And then finally, we have seizure, which is the sudden surge of electrical activity in the brain, which leads to various physical and mental symptoms. All right, we made it through diagnosis. Now we're getting to the real meat and potatoes of the presentation, which is our treatment. So the goal of this portion of the presentation is to discuss determining a treatment pathway with the principles of ethics and clinical neuroplasticity as our guides. I think one of the kind of hot topics in speech language pathology, and it's been, I would say, ambiguous over the years, is how to approach the treatment of different cognitive impairments. What is evidence-based? What is not? What is treatable via our types of services? What is not treatable via our types of services? And how to provide the correct level of counseling regarding these things. And it's been a little tricky because there are certain governing bodies within our profession that would say that, speech language pathologists should be following on caseload anybody with a cognitive impairment. And then we also have to consider the evidence base, which oftentimes is not in agreement with that statement. This will kind of elucidate that dynamic within the field. All right, so the two things we have to hold in the balance are our clinical ethical principles and then the pillars of neuroplasticity. So your VARCI clinical ethical principles are beneficence, non-maleficence, autonomy, and justice. And then our pillars of neuroplasticity are our synaptic plasticity, neurogenesis, and functional reorganization. So clinical ethical principles, first up, we got beneficence, which is essentially that the patient needs to benefit from our services. What is the nature of their illness? What are their goals? What are their treatment options? How likely do we expect that they will actually benefit from what we are doing? Is what we are doing taking away time from something that would actually benefit them more? Are we overexhausting the patient to have no real functional outcome versus is our therapy effectively changing how they're going to operate when they leave here? What is the effect if we don't see them at all? And then if we treat them, what is our time frame for treating them? Like how long do we expect them to benefit versus like when do we need to call it if they've had a therapy plateau or if we don't feel like they're benefiting anymore? And then next up we have autonomy. So it is our job to explain what we're doing with the patient and why, to explain risks and benefits. They should give consent to any treatment we provide. And if they are not competent to provide consent, then their power of attorney, healthcare surrogate should be consulted to see if they agree with the plan of care. In general, it's important that the patients, their family members are involved in what's being formulated for them. So our ethical considerations are that we have to expect that what we are doing is going to change their functional outcome, and that's guided by evidence-based practice. That's why we go back to the research. Research is still growing in this specific field, but there is a good base level of research kind of showing what we would expect to functionally change within a certain time frame and what we wouldn't, which I will review here shortly in a minute. And then we also have to make sure that whatever we are doing aligns with their goals. Sometimes we get patients who come here who do have a brain injury, like an acute TBI, but maybe their profile is pretty mild, like maybe their memory's not great, maybe they're a little inattentive, but overall they're doing pretty well. And they might look at me and say, hey, all I want to do is go home. And to go home, all I got to do is get up 12 steps. And you have nothing to do with getting me up those 12 steps. Therefore, I don't want to do this therapy. And that's absolutely appropriate. There's always an option of if, for instance, in the inpatient rehab setting, that what I offer does not align with their goals, we can always refer them out to outpatient care if they decide that at that time they wanted to address any cognitive changes. But it is not my job to force anyone to do cognitive therapy. And sometimes they're absolutely not interested in doing it. And then on other times, it's like all our patients want to do. And then we try to offer more as able. Now we're going to discuss our pillars of neuroplasticity. So neuroplasticity is why rehab really exists, and especially inpatient rehab. It's why we exist and why we see patients acutely versus years after their injury in most cases. Neuroplasticity is our brain's ability to adapt structurally and functionally reorganize and to overcome injury, as well as just to adapt, grow, and change over time. The three different areas we look at in terms of neuroplasticity are our synaptic plasticity, our neurogenesis, and our functional reorganization. Synaptic plasticity is what occurs following frequent repetition of a skill. Neurogenesis is our actual neuronal regeneration and collateral sprouting to build new neurons. And then our functional reorganization is we're reallocating a task from that was maybe previously taken over by a part of the brain that's been damaged, and we are reallocating it to an underutilized region of the brain. And though the brain always has a potential for change, you can change up until like the moment of your death. There are mechanisms that heighten the brain's neuroplastic response following a focal acquired brain injury. And today, the one I will specifically discuss is BDNF, which is brain-derived neurotrophic factor. We're going to look at this as a functional measure of heightened neuroplastic potential. So recent research has been amplifying brain-derived neurotrophic factor, or I guess the research into brain-derived neurotrophic factor, which I will now call BDNF for the remainder of this presentation, and its role in neuroplasticity and neurorestoration. So neurotrophic factor, or neurotrophins, is a family of proteins that are vital in differentiation, maturation, and survival of neurons, and really structural brain change. Although most neurons in the brain remain unchanged after birth, some of our neurons can grow and differentiate in a neurogenesis process, which importantly involves BDNF. BDNF has the potential to facilitate recovery from traumatic nerve injury and to mitigate neurodegenerative diseases. So it is clinically measured via serum, plasma, or saliva levels. It's not something that you would see someone just like magically had done in their labs. And then if you ever decide to go down a rabbit hole and look up research on BDNF yourself, there's some interesting considerations. For instance, they found that some people genetically produce more receptors for BDNF than others. So some people genetically, they're finding, are primed to have better brain injury recovers than others. And none of us know what group we live in unless you went and specifically got this measured. Increased BDNF levels have been measured following various forms of stress or injury to our peripheral nerves, spinal cord, or brain. as well as following moderate intensity exercise, which is why they say doing exercise makes you smarter and helps prevent neurodegenerative diseases as we age. It's because exercising is giving us more neurotrophic factor to bulk up our brain, as well as our muscles. Decreased BDNF levels have been measured following chronic stress, potentially mediated by DNA methylation changes. Stress-induced neuroinflammatory responses. So lower BDNF levels have been correlated with higher levels of inflammatory markers and elevated glucose levels. You'll see that I have bolded elevated glucose levels because and I feel like the prevalence of diabetes, especially in rehab, is significant. And we often we'll find people who are admitted and they don't have any acute neurological changes, but they don't necessarily do fantastically on their cognitive screeners when they get here. And I would theorize that a lot of times our patients have diabetes or have had difficulty controlling their glucose levels over time. And so I thought this was really interesting because basically uncontrolled glucose over time lowers your brain's BDNF or how much BDNF your body produces to support your brain. Decrease in the expression of BDNF is seen in many neurological diseases, including Alzheimer's, Parkinson's, Huntington's, bipolar, and then decreased serum levels of BDNF have also been found in patients with MS. No differences in BDNF have been found between people with delirium versus people who never developed it. So increased brain-derived neurotrophic factor lends itself to an increased expected response to restorative treatment. Restorative cognitive therapy in the most recent systematic reviews has been supported for the following deficits in the following patient populations. Excuse me. I have a tickle on my throat. I'm going to take a drink very quickly. All right, I'm back. BDNF. Restorative cognitive therapy has been found to be beneficial for people with attention deficits following brain injury or stroke, visual scanning of neglects after right hemisphere stroke, compensatory strategies for mild memory deficit, language deficits following left hemisphere stroke, social communication deficits following TBI, metacognitive strategy training for deficits in executive functioning, and comprehensive holistic neuropsychological rehab to reduce cog and functional disability after TBI or stroke. Decreased BDNF lends itself to a decreased expected response to restorative treatment. Restorative cognitive therapy has been unsuccessful in the following populations. Parkinson's disease, toxic encephalopathy, encephalitis, mild cognitive impairment, Parkinson's disease-related MCI, and mild to moderate dementia. So there's some caveats to this. Sorry, guys, bear with me. All right, I'm back. There's some caveats to this. Like, there has been some modest effect on global cog in patients who do cognitive stimulation programs in like skilled nursing facility type environments. And in brain cancer, BDNF increase has also been associated with possibly increased tumor bulk, and then following a cranie, however, would be expected. So you'd have, they found that there's higher levels of BDNF in patients who have a brain tumor. But once the tumor is removed and you start chemo actually drops your BDNF production. So we would expect you to be less responsive to restorative therapy while undergoing a chemo process, which is kind of where the school of thought of prehab or pre-rehabilitation is really starting to bulk up. All right, the cognitive treatment paradigm. We got three main schools here. We got restorative, compensatory, and medical intervention and support. Sometimes you do all of them. Sometimes you do one of them. Sometimes you do a few. Sometimes you do none. Depends on your patient. Restorative therapy aims at reinforcing, strengthening, or restoring impaired skills. Compensatory therapy is a way of bypassing or compensating for an impaired function. And then this often includes assistive technology, calendars, electronic memory devices, alarms, or reminders. Medically supportive therapy, which includes pharmacological therapy, is to optimize the body and brain for healing. First up, we got restorative therapy. It's chosen for patients with the following profile. They have a cognitive impairment secondary to an acquired brain injury, an acute nature of the impairment. They do have functional goals of care, but it's not necessarily useful for patients who have an ongoing impactful neuroinflammatory process, think like sepsis, or if they have severe baseline cognitive impairment. So the presumed increase in brain-derived neurotrophic factor supports these patients in making rapid and functionally impactful improvements. Around 10 million people get a TBI every year worldwide, and they can be classified as mild, moderate, or severe. In acute care, we'll often use the Rancho's Los Amigos scale to track their progression through their journey to recovery. In moderate to severe TBI, cognitive function is not expected to return to baseline following 2 years. But in mild TBI, cognitive function is expected to be near baseline following 3 months. Patients with mild to moderate cognitive impairment following TBI are expected to make the greatest gains in restorative therapy. So following TBI, you can see this variety of cognitive changes. Impaired attention, which I'm not really sure how that's different from decreased concentration. I'm sure it is, but easy distractibility, impaired visual spatial conceptualization, slow verbal visual information processing, impaired memory, communication disorder, poor judgment, and poor executive functioning. Repeated exercise of standardized cognitive tests of increasing, restorative therapy involves repeated exercises of standard cognitive tests or tasks with increasing difficulty level targeting a specific cognitive domain. So the cognitive domain, domains that we typically treat here are attention, memory, visuospatial perception, language, communication, and executive functioning. So let's go over a couple of case studies. I have 2 of the patients we recently had here. I worked with them both. I love them both. Number 1, Miss HH. She had a syncopal fall at home and hit her head on her tile floor. She was diagnosed with a subarachnoid hemorrhage, a subdural hemorrhage, and right temporal occipital fracture. Her head CT, which was on December 12th, said that she had a subarachnoid hemorrhage in her bilateral frontal lobes and right temporal lobe, but no midline shift. She did receive a PEG while she was admitted due to just poor initiation to eat and really poor intake. So she came to rehab and her initial testing was completed on January 6th. It showed she had a moderate cognitive impairment. She scored a 32% memory, 44% attention, 52% problem solving. Her goal was she wanted to go home. She had these 3 dogs that she just like desperately missed and thought that her husband and her daughter were like conspiring against her to keep her away from her dogs, which was very upsetting for her. She was having a hard time reasoning what the point of coming to rehab in the first place was and why she would benefit from being here versus just going straight home. So in her restorative therapy, we really worked on cognitive endurance because her first few sessions, really, I would say close to the first week that she was here, she fatigued incredibly quickly. And as she fatigued, she became more agitated. And so initially, we were working on really just some nice basic sustained attention. I would usually have her read like maybe a couple paragraphs of an article. Our initial goal was just that she would read to me for 2 minutes, and then the timer would go off. I'd give her a 1-minute break, and then she'd have to, once the minute was up, read to me for another 2 minutes. And she still required quite a bit of prompting to get through that task. 1 week later, she did discharge, and in her final session, she was sequencing 4-step tasks independently and could focus for 13 straight minutes instead of just 2. It was a pretty major difference. When she was first admitted, she required a lot of encouragement to keep going. And by the end, she didn't need to be cued once to get through an hour-long session, which was a big improvement. Ultimately, she went home. She went home with her husband and daughter, back to her dogs. She was contact guard by the time she left here, so physically doing really well. And just needed some supervision for safety. She was very happy to go home. I'm very appreciative of our services after spending time here. Case study number 2. We had a patient named DC. She had a history of multiple myeloma. She had AFib and was found down at a gas station in VTAC. She required CPR and defibrillation. After that fall, she sustained a bilateral temporal intraparenchymal hemorrhage, right side greater than left, a traumatic subarachnoid hemorrhage, an intraventricular hemorrhage with subfalcine herniation. She was intubated on arrival. She also got a PEG due to poor initiation to eat and just generally poor intake. So when she was initially admitted on December 17th, neurocritical care charted that she had a severe TBI and encephalopathy due to her cardiac arrest. Her sister, who she was very close with her 2 sisters, they were here to support her throughout her stay. They were wonderful. And one of her sisters described when they first went to go see her in the ICU, she said her arms were like her hands were balled up into fists and like contracted into her body. She said, I didn't think I ever thought I would see her walk again. So initially when she got to us on January 3rd, she had a moderate cognitive impairment with markedly reduced orientation, memory, attention, problem solving per the scan, which is what we gave her. And then she was really hard to wake up. She was constantly asking me to go back to bed. Our first session, I really don't like treating people in room. I always try to get them down to my office because being near a bed makes me feel sleepy. So it definitely makes the patients feel sleepy. And we had to I went and I helped assist her to like sit up at the edge of the bed, and she like flipped her legs right back in bed and was like, "You just gotta let me lay down. You just gotta let me lay down." We sort of did that song and dance for the remainder of the hour. Her goal was to go home independently. She lived independently, highly independent lady. Nobody else in the house typically. And so her restorative therapy targeted memory, attention, executive functioning, cognitive endurance. And then 2 weeks later, DC did awesome. She, as you can see on the screen here, she jumped in every single category. And by the end of her stay here, she presented as a mild cognitive impairment and still had some memory deficit, but she was highly organized at baseline. And so she had a lot of great compensatory skills already kind of in her back pocket, ready to go. Slightly inattentive. Overall, she was going home. The sisters were going to hang out with her at home for a while until they felt like she was reestablished. They had some friends that they could hire as like private caregivers throughout the week. And yeah, she had a really great outcome. Great example of a really good recovery. And improvement in her encephalopathy from her cardiac arrest probably aided in her overall improvement presentation. But yeah, DC did great. Oh, and we got to take her peg out while she was here, which was awesome. Moving on to compensatory therapy. Compensatory therapy is appropriate for people who have a cognitive impairment. Doesn't necessarily have to be secondary to an acquired brain injury, as is defined in this presentation. Acute or chronic nature of impairment impacting safe discharge and functional goals of care, but very much so enhanced by caregiver support. They are really not appropriate for compensatory strategy training if they still have an impactful neuroinflammatory process. So if they have ongoing, like let's say they have really severe hepatic encephalopathy and they come to rehab and the plan is still to go home, they're like on the transplant list, waiting for a liver. They are fluctuating day to day. No one day is the same. That would be an appropriate situation for good caregiver training, but we wouldn't expect that the patient would make a lot of functional change until the underlying cause of the encephalopathy was addressed. Their treatment schedule is often modified or reduced. The patients can either carry over strategies or they need their caregivers to help them. So it's been found to be useful in patients with toxic encephalopathy, things like memory aids, internal memory strategies, or encephalitis. It's associated with high levels of functioning in daily life among older adults. And yeah, you're just finding strategies to target direct functional things that they need to do on a day-to-day basis. Like maybe it's like a list of the steps to use the coffee maker. A lot of our delirious patients get lots of signs slapped up in their room pretty shortly after arriving. They're like, "You are at Tampa General Rehab." Actually, it doesn't even say that. It says, "I am at Tampa General Rehab. I am here because I had a liver transplant and I'll be here for about this long," that sort of thing. Cognitively normal and mild cognitive impairment older adults had greater levels of using compensatory strategies than those with dementia. So they work best in patients who are like mild to moderate. Once a patient is more severe in presentation, they may no longer effectively learn the strategy we're trying to train them on. And then last but not least, medically supported therapy. So this is for patients with any cognitive impairment, plus or minus an acquired brain injury. If there is an acute impairment and an impactful neuroinflammatory process. In order to improve a patient's cognition, we have to treat the underlying cause. Families and caregivers should be prepared that encephalopathy and delirium can take time to resolve. And the patient will likely require support for their cognitive activities, daily living on discharge. A lot of our patients with encephalopathy or delirium need to, honestly, they best clear up if we can get them home, but they don't totally clear up until we can get them home. And so we have to explain this to the family that the person's still going to need a lot of support in the beginning. It's not going to we're not going to be able to magically send them home identical to the way that they were before. But if we can get them strong enough and well enough to go home and reestablish routines and automaticity, they're more likely to thrive. So medically supportive treatment could look like oxygen therapy for short-term anoxia, lactulose, low-protein diets, antibiotics, consideration of transplant for hepatic encephalopathy crowd, dialysis, kidney transplant, or pharmacy for uremic encephalopathy. For toxic metabolic, titrating meds that are making it worse, medical treatment to optimize metabolic function. For diabetic encephalopathy, got to get their glucose levels managed. For hypo or hypertensive encephalopathy, pharmacy, manage their blood pressure. I'm going to very briefly go over these case studies. RH was a lovely gentleman who had a septic knee and came to rehab, and he was so lovely and just so not on the same planet as I was when I met him. And so while he was here, he started presenting with stroke-like symptoms. His knee was oozing, wasn't looking good. He went back to acute care. Before he went back, he did complete a slums. He got a 54% on it. He went back to acute care, got his antibiotics sorted out, and knee infection got better. And once he returned, he tested at a 90%. He was doing so much better, was essentially functional. And our second case study is a lovely lady who had severe sepsis because she had a UTI. She came in pretty shortly after starting her antibiotics. She scored a 13 out of 30 on the MOCA. And she was really concerned about this. She hated that she did not have a great score. We came back in a week. She scored 27 out of 30, which is considered functional on this assessment. And all just because she just needed a few days for her antibiotics to kick in. So these things are often interchangeable. They don't occur in isolation. It's really just identifying which the patient can benefit from. And ultimately, no cognitive treatment is appropriate for someone who has no functional goals, or if they're straight up declining services, because we need to make sure that we are respecting autonomy and also considering beneficence. That's the end of this presentation. Here is a long list of sources. Sources. Sorry for coughing.